All right, let's dive right in. Today, we are tackling a super important, high-yield topic for your nursing exams: nutrition for clients with cancer and HIV/AIDS. Seriously, mastering this stuff isn't just about passing a test. It's about understanding how food literally becomes a form of therapy that can make or break a patient's outcome.
First things first, burn this into your brain. If your client with cancer is losing weight without even trying, that is a massive waving red flag. It is a huge sign that their body is in metabolic chaos. And you know what? It predicts worse outcomes. This is a top-tier, absolutely critical nursing assessment point. So here's our game plan for today. First, we're going to hit the big picture: why nutrition is such a big deal for these patients. Then, we'll get into the absolute must-knows for cancer. After that, we'll pivot to the specific priorities for HIV/AIDS. And we'll wrap it all up with what it's all about: using your clinical judgment to make the right call. Okay, so why do we care so much about this? It's because both cancer and HIV can throw the body into what we call a hypermetabolic state. Just picture an engine that's stuck in the red, running way too hot and burning through fuel like there's no tomorrow. That's what's happening inside these patients, and it leads to that awful weight loss and malnutrition that we're trying to fight. And this right here, this is the core principle. If you get anything from this, get this: good nutrition is not just a nice to have. It's not optional. It directly affects whether a patient can even tolerate their chemo, how strong their immune system is, and ultimately, their quality of life and survival. It is a non-negotiable part of their treatment plan. All right, let's get into our first deep dive: cancer. I need you to pay super close attention here, because these are the concepts that NCLEX and ATI just love to put on their exams. We're talking key definitions, numbers you have to know, and the interventions that you'll be tested on. You have got to know this term: cancer cachexia. Now listen, this is not simple starvation. This isn't just someone who isn't eating enough. This is a complex, nasty syndrome where the body is actively breaking down its own muscle. And here's the kicker: just feeding the patient more calories won't stop it. It is a huge, huge red flag for a poor prognosis. And right alongside cachexia, we have sarcopenia, the loss of muscle. But here's the tricky part, the part that you as a nurse need to catch. A patient can have sarcopenia even if they aren't super skinny. This is why someone might look okay on the outside but be incredibly weak. This hidden muscle loss is dangerous because it dramatically increases their risk for chemotoxicity. It's a vital assessment finding. Memorize these numbers. Seriously. For calories, we are shooting for 25 to 30 kilocalories per kilogram of body weight. That's our goal, just to hold the line and keep them from losing more ground. And for protein, we have to push it. We need at least 1.0 to 1.5 grams per kilogram. This is not the time for a low-protein diet. We are in a full-on battle to save every last bit of muscle they have. Okay, let's put this into practice. Classic NCLEX-style question coming at you. You walk in the room, your patient's on chemo, and they tell you, "Everything tastes like I'm chewing on pennies and I have zero appetite." What are you gonna do? What are your priority nursing actions? Think about it. Okay, here are your answers, your priority interventions. That metallic taste? Switch to plastic utensils. It's a simple trick, but it really works. And why serve food cold or at room temp? Because hot foods have stronger smells that can make nausea and food aversions way worse. And since they have no appetite, we focus on small, frequent meals that are packed with calories and protein. We have to make every single bite count. These are testable, real-world nursing actions. Okay, everybody stop. We're shifting gears to a massive safety alert. When a patient's white blood cell count tanks, they become neutropenic. Basically, their immune system is gone. And all of a sudden, food, something that's supposed to heal, can become a source of deadly infection. This is all about patient safety. This list is non-negotiable. There is no wiggle room here, absolutely no raw or undercooked anything. No rare steak, no sushi, no runny eggs, no unpasteurized juices or dairy. And salad bars or buffets, forget about it. They are a germ paradise and are completely off limits. You have to know these precautions cold to keep your patients safe. Now, let's pivot to our second population, clients with HIV and AIDS. Now you'll see some similarities to cancer, like that risk of wasting away, but there are also some really unique priorities that we need to zero in on. Just look at this comparison. Even when a client with HIV is asymptomatic, they feel totally fine, their body is already working about 10% harder than normal. But once they become symptomatic or develop AIDS, whoa, that need for energy jumps by 20, even 30%. Their body is in a constant, high-stakes fight against the virus. So for HIV, your nursing priorities really boil down to three big things. First, antiretroviral therapy, or ART. You absolutely have to know which meds need to be taken with food and which need an empty stomach. It's a huge deal for adherence and effectiveness. Second, just like we talked about, food safety is critical because of their suppressed immune system. And third, we have to think long-term. People are living longer with HIV now, so we have to manage comorbidities like bone loss and heart disease with a good diet.
And that brings us to our final section, which is all about putting the puzzle pieces together. This is about making the right call, using your clinical judgment to apply all this information, just like you're going to have to do on the floor and, you guessed it, on your exams.
You have to know this hierarchy. The golden rule of nutrition support is, if the gut works, use it. So we always, always, always start with the oral route first. We encourage food, high-calorie snacks, supplements, anything to get them to eat. If that's not enough, but their GI tract is still working, we move to enteral feeding, a tube feed. Parenteral nutrition, or IV feeding, is the absolute last resort. It's only for when the gut is completely out of commission. And here is a really critical distinction. For patients with advanced cancer, when they have that cachexia we talked about and it's just not responding to anything we do, our goal has to shift. We are no longer trying to aggressively reverse weight loss. Instead, our focus becomes all about managing symptoms, promoting comfort, and maximizing their quality of life. It's a compassionate and important change in the plan of care. So let's end with this. For your clients with cancer and HIV, nutrition is never just about comfort. It is a powerful, critical, indispensable part of their medical therapy. Understanding these principles helps them tolerate treatment, helps them fight infection, and helps them maintain their strength and dignity. That's what you need to know, and that's why this all matters so much.